Hello, my name is Christine Martinez, and I'm going to be going over patient education of cholecystitis. What is cholecystitis? Cholecystitis is the inflammation of the gallbladder. The inflammation of the gallbladder is often due to bile getting stuck in your gallbladder, and this can cause your gallbladder to be tender, swollen, frail, and even rupture. Pathophysiology and etiology. Bile is produced by your liver and is stored in your gallbladder and released into your duodenum, which is the smallest, which is a part of your small intestine. And when you eat, your bile assists in digestion. Cholecystitis is often due to a gallstone that's getting stuck in your cystic duct. Your cystic duct is the duct or the tube that connects your gallbladder to your small intestine. Clinical presentation. When patients come to the hospital with cholecystitis, what we often see is nausea, vomiting, abdominal pain. This abdominal pain may or may not radiate to the shoulder blades. And a telltale sign is a positive Murphy sign. Positive Murphy sign is when the provider is palpating the right upper quadrant. They're going to ask the patient to take a deep breath in, and often the patient stops the inhalation due to the intense pain when they're palpating the right upper quadrant, and that indicates positive Murphy sign. Once the physical examination indicates cholecystitis, it's often confirmed with further diagnostic tests such as labs and imaging. Labs that indicate cholecystitis is a CMP, which stands for Complete Metabolic Panel, and a CBC, which is a complete blood count. Our CBC is going to show us an elevated white blood cell count. An elevated white blood cell count is going to indicate inflammation and infection. And then when we're looking at our CMP, we're going to look at our AST and our ALT, which are our liver enzymes. We're going to be expecting these to be elevated also with cholecystitis. An elevated AST and ALT shows bilirubin being backflowed because the bile can't drain into the gallbladder due to the blockage of that cystic duct by a gallstone. When the bilirubin backs up, it causes liver inflammation and elevates those AST and ALT liver enzymes. And then also you're going to have an elevated total bilirubin due to the same reason. The cystic duct is blocked typically by a gallstone. The backflow of bilirubin goes into the bloodstream and elevates the total bilirubin lab. The other diagnostic that's typically done to confirm cholecystitis is a CT scan. Once a physical exam and the labs indicate cholecystitis, a CT scan is done often to confirm this diagnosis. Statistics. So if you have cholecystitis, you are not alone. 3 to 10% of all patients who come to the ED are diagnosed with cholecystitis. So it's very common. We see it every day in the ED here. Risk factors. So risk factors for getting cholecystitis, unfortunately, being female, you have a higher chance of getting it than males. Over the age of 40, if you've had gallstones in the past, you're at a higher risk of getting cholecystitis. Being overweight, having a history of diabetes, and then also a family history of cholecystitis. Common course of treatment. Now, this is dependent on the cause of cholecystitis, but since gallstones are about 95% of the cause of cholecystitis, we're going to go along the course of gallstones. Laparoscopic cholecystectomy, or also known as a lap chole, is the most common cause or course of treatment for cholecystitis. When you have a laparoscopic cholecystectomy, a surgeon will make usually 4 small incisions into your abdomen, and they insert a camera and then 3 instruments into your abdomen to remove your gallbladder. All right, medications. So I have your medications organized into 2 separate columns. One column is your inpatient medication. So when we find out that you initially have cholecystitis, what medications you're going to get, you're going to initially get IV fluids. They're not going to want you to eat or drink because you're going to have nausea and vomiting with eating and drinking. And plus, prior to a procedure such as surgery, you can't eat prior to that procedure also. So you're going to not be able to eat. We're going to give you IV fluids to manage until you are able to eat and drink. And then on top of that, the surgeon typically likes the patient to get an antibiotic such as Zosyn. What this antibiotic is going to do is it's going to calm down that gallbladder so that it's not as frail and angry. So when they go and take it out, it's not, it decreases the risk of complication when they're removing that gallbladder when it's not as inflamed. And then there's Zofran for nausea on the inpatient side, just to treat the nausea and vomiting. And then typically an IV pain medication such as morphine or Dilaudid. I did put Dilaudid on the slide because it's more common than morphine. Morphine has a lot of side effects such as causing more nausea, and it's not as effective as pain management as Dilaudid. So I see Dilaudid being given more than morphine. Discharge medications with after you've had your laparoscopic cholecystectomy is initially we're going to give you stuff for pain management. So Tylenol, it's a non-narcotic form of pain management, and ibuprofen, also another form of non-narcotic pain management. The provider is going to want you to alternate between Tylenol and ibuprofen for pain management. And then another layer on top of that, so this is not to replace the ibuprofen and Tylenol, is the roxicodone. The doctor wants a patient to take roxicodone when the pain is uncontrolled with Tylenol and ibuprofen. And then also they're going to be prescribed Zofran to control any nausea postoperatively. Upcoming appointments or follow-up appointments. Once you've had your laparoscopic cholecystectomy, you're going to have to follow up with your surgeon. Surgeon typically wants to see the patient 1 to 2 weeks after surgery. We always provide all of our patients with the name of their surgeon, their office address, as well as phone number. And if we can, we do go ahead and schedule that appointment for the patient ahead of time. In addition to following up with a surgeon, our patient needs to follow up with their primary care provider. We do not schedule that appointment for them, but we do prompt them to call and follow up with their primary care provider once they get home from the hospital. All right, very important after you have your laparoscopic cholecystectomy, surgical site aftercare. First, we want our patients to keep the site clean and dry. We're going to tell them once you go home, go ahead and shower as normal. While you're in the shower, go ahead and let the water run over your surgical incisions. Do not scrub at the surgical incisions, wash around the surgical incisions, and then when you get out of the shower, we want you to pat dry with a towel. Once again, do not scrub even with a towel at those sites to dry them off. We do allow the patients to shower after having the surgery, but we do not want them to get in the bath or soak in a tub. Rules are: do not submerge those incisions in water. No tub baths, no pools, no lakes, no ponds, no rivers, no ocean. No submerging those incisions in water. The steri strips that are over your incision sites, they should come off on their own. Do not pick them off. Do not try to pull them off. Now, if the steri strips are still there after 1 week, it's generally okay to gently remove them, but don't pick them off. Don't be aggressive with it. Activity restrictions. Once you've had surgery, your provider does not want you lifting anything over 10 pounds for 2 weeks. General rule of thumb is if you have to strain or struggle to lift it, do not pick it up. In addition to not lifting anything over 10 pounds, they also want you to get up and walk after surgery. This walking is going to promote circulation and prevent blood clots after surgery. The minimum amount of times you have to walk per day after surgery is 4 times per day. Generally, we prompt our patients and encourage them to not sit for more than 2 hours at a time. So after about 2 hours, you need to get up, you need to walk, do some circles in your house to get the blood flowing. This is going to prevent blood clots. And then we do encourage our patients to wait 6 weeks before they resume their normal workout routine or any type of strenuous physical activity. All right, since we are discharging patients with narcotic medications for pain control, we always have to teach our patients about opioid safety. First and most important, we need to tell our patients to take them as prescribed. In addition, no driving. You're not allowed to drive, no operating heavy machinery while on narcotic medications. This includes equipment such as riding lawnmowers. People don't think about it, but we also discourage riding lawnmowers or any type of heavy machinery while you're on narcotic medications. We encourage our patients to keep their medications in a clean, dry environment. Typically, this is not your bathroom. And also to keep them away from children. On that same line, not only are we keeping them away from children, but you are not allowed to share your opioid pain medication with anyone. Diet. After having your gallbladder removed, we encourage all of our patients to start with a low-fat diet. Your body will slowly adjust, some better than others, so it's smart to slowly introduce healthy fats as your body tolerates it. There's no time frame. Everybody's body is different. We do encourage our patients to eat smaller meals more frequently so that when you are taking in any type of fats, even if they're a small amount of healthy fats, they're in smaller amounts at a time, so your body is able to tolerate them better. When they do eat protein sources, we want our patients to eat lean protein sources such as chicken, fish, tofu, beans. Patients need to avoid all high-fat, greasy, fried foods. And then also, we want our patients to increase their water intake. And this is because they're more likely to have diarrhea until their body adjusts to their gallbladder not being there anymore. So with a high diarrhea or a higher chance of having diarrhea, you're going to be likely to be dehydrated. So we want our patients to increase their water intake. All right, post-operative complications. What do we do when we have post-operative complications? There's two different columns. We want our patients to either call their surgeon's office or go directly to the emergencies department. So we want our patients to call the surgical office if their pain is uncontrolled with their prescribed medications, if they have any questions or concerns about their procedure or their incision site. Also, if they're unable to have a bowel movement 5 days after surgery, they need to call their surgical office, or if they have any surgical sites that are starting to open. We need our patients to go to the emergency room if they're having a fever of 101.6 or higher, shortness of breath or trouble breathing, if they're having any uncontrolled bleeding, if the patient is unable to keep down any foods or fluids, or if they have any purulent or foul-smelling drainage from their wounds. Any questions? These are my references for my PowerPoint. Thank you.